image guidance now has secured a very stable place in the intervention in our country also. And that's a good news. So today I am going to speak on image guided PCI. I have created the talk as a case-based presentation where, many times we have been successful, a few times we have failed, and the reasons of success and failure and how imaging helped us identifying the complication, even reaching the success, etc. So the first case was a 68-year-old male, diabetic, hypertensive, hypothyroid, and inferior wall MI, history of inferior wall MI before 6 years, presented with class 2 angina on medical management, mild LV dysfunction. It's not moving, the slide. Okay, yeah, it's moving here. Okay, it's not moving here. So it looks a very simple lesion. But here, I had problem with a regular wire, extra floppy run through, and I struggled even with balloon. It was simply not entering. And ultimately, I had to use pilot 50, and with a 1.5 balloon, I could cross. It looks very simple. But when you see, after pre-dilatation, when I did optical coherence tomography, this was the picture. It is a recanalized thrombus, very old chronic recanalized thrombus with a honeycomb appearance. So then we fixed it. This is the picture. We fixed it, and then OCT and the angiographic result was perfectly clean. So sometimes, you have to think of it, 6-year or a very old MI and presenting with patient presenting with simple lesion can be a functional chronic total occlusion. Another case is a 59-year-old man, diabetic, hypertensive. PCI of LAD was done before 4 years and presented with anterior wall MI to us with a severe left ventricular dysfunction. It was an interesting angiographic view, and we thought that it could be a spontaneous coronary dissection. Because what else? It looks like a flap. The stent is in the proximal LAD, and it looks a very awkward. There is some ectasia there. And we worked on it. It looks very simple at this point of time. We did left main to LAD and then kissing balloon and a perfect result. But then half an hour we spent perspiring and thinking what is going wrong. This was the picture. When we did it, initially the wire went through the strut in the main artery, and then we had to correct the wire, going through the proper channels. Now we did it properly with kissing balloon and everything. Interestingly, we did both OCT and IVUS image here. This is an OCT image. Just focus here on the shaft. It is now in the different channel, and now it is coming in the left main. There was an aneurysm which happened at that point of time in the edge of the stent, in the proximal edge of the stent. We confirmed even with IVUS here. This is a true lumen. And now suddenly you see the shift of the shaft into a different cavity. And this is the original cavity. And then again coming, you can see the left main. So this happened. And these are the still pictures which we clearly show the lumen, the aneurysm, the shaft was going through, and then the correction was given, and this was a perfect picture. So these are the problems, you can identify. Otherwise, without imaging, you remain clueless and you don't know what you are doing. A very interesting case, a 25-year-old female presented with ACS, ECG showing inferior wall STT changes, raised troponin, a selective coronary angiogram, giant aneurysm. And we did MRI of the brain vessels, abdominal, just to rule out Kawasaki type of phenomenon, whatever. And she had moved around everywhere. Everywhere the surgery was advised. She was 25 and ready to marry after 1 year. She came with the fiance and the parents. And see, this is what it is, impending and rupture, aneurysm, huge aneurysm with impending rupture. There must be a good amount of clot inside too. When we measured the size of aneurysm, it was almost like 29-30 millimeter. And the papyrus stent, longest stent available was 26. What to do? We thought over it. Okay, you cannot overlap two covered stents. We gave the option of covered stent under image guidance. You know, inside this cavity, which is a very unstable type of aneurysm, here my colleague Sanjay came out with a brilliant idea. We created a platform with a metal stent, 38 millimeter Giants Expedition measured, 38 millimeter Giants Expedition stent was deployed, stented the region, and then overlapping two papyrus stents were deployed one after the another. You can see this is the another papyrus, and the aneurysm is gone. We checked it with OCT guidance. This is how we worked on it. We checked it using the OCT guidance. You can see the perfect deployment. The aneurysmal cavity collapsed because blood flow stopped going there, and you can see all the blood collection all around the site of the aneurysm, and you can even see the overlapping of the stents. This is how it looked, at the normal segment of the Giants Expedition and inside the aneurysm. We called her back again after 9 months, and you can see the perfect result. We even did OCT guidance at that point of time. And you can see the perfect result. There was some proliferation at the overlapping site, absolutely acceptable. There you see some proliferation only at that site, and then again the normal segment. Patient is doing fine. It is almost 3 years. So this is one way, because otherwise we had no choice but to give her a graft on the right artery, and which was pretty not acceptable for them. This is a 60-year-old female, hypertensive diabetic, presented with recent inferior wall MI history and mild left ventricular dysfunction. PCI to RCA lesion was planned. And see what happened. First injection, and there is a spiral dissection. Through and through, going right up to the PDA, and just at the lesion site. Complete plan was changed. Now we wanted to dilate, stand, do proper image guidance to see everything is fine. Instead, first worry was to prevent the extension of this dissection in the ascending aorta, because if it extends, it will go up to innominate and it can create disaster. So we changed our strategy. We fixed the ostium first. And once we fixed the ostium, of course, there were a lot of issues. Patient had pain, hypotension, everything. We deployed another 2 stents and reconstructed the artery. It looks pretty good. And in different views we checked. We didn't compromise any of the major branches. And you can see the optical coherence tomography image. It is very acceptable, with some areas of intramural hematoma happening, beyond the dissection area, but perfectly acceptable result, and patient remains stable. Dissection and hematoma, we are using IVUS and OCT, but in this particular situation, many times we get a better more information with the OCT guidance, which is a very regular affair in our lab in almost 50% of coronary intervention. We have an investigator-initiated IOPUS trial where simultaneous IVUS and OCT imaging have been done for the same lesion, and you can see This is how it looks in IVUS. This is how it looks in OCT. Dissection and hematoma looking in IVUS and OCT. Another image. A huge hematoma there, which looks like this. In OCT, if the artery is very big, sometimes, you can misinterpret this hematoma. In IVUS, it looks better in the bigger arteries. And another example. Another case of a 68-year-old man, hypertensive diabetic, class 3 angina, fair LV function, left main bifurcation Medina 111, syntax score 18, mini crush of LMCA lesion, bifurcation was planned. This was, in the beginning when we got a new software of the OCT, that is before 3 years, I suppose, or 4 years. And it was done in a perfect copybook style case, mini crush. Everything was done as per the book, LAD to LMCA OCT run. And this is how the circumflex looked. Distal crossing was done, again dilated, and then circ to left main run and LAD to LMCA run. Perfect result. And this is what you see as a result, end result. Another case, this was a 66-year-old male, class 3 angina, hypertensive diabetic, angiography, left main trifurcation. Of course, if you consider bifurcation, Medina 111, high syntax score, patient refused surgery, and we accepted for intervention. Here, rather than creating crowding around the area of carina, we have used the technique, a mini crush, and for time being, we became selectively blind to the ramus intermedius. Because it is extremely tight lesion there, we presume that there is a good amount of ischemic preconditioning. Even if it occludes, we'll see what happens. And then we worked on it, kissing a mini crush, kissing balloon, and perfect result. And the ramus is flowing as it is. And this is how it looked in the OCT. You can see the perfect result. And we have now almost the data of more than 200 left main bifurcation done under OCT guidance. And I'll show you the original, the standard teaching is, you have to identify whether, you have to see two things, link free carina or link connecting carina, and distal crossing or proximal crossing. Standard Japanese teaching, because Japanese have done the maximum work on it, is link connecting or link free carina is not in the hands of the operator, whatever you do. But proximal and distal crossing, you can always think of. And they say that more you do distal crossing, you get a better cosmetic result. And of course, MACE and TLR rates are also low. But in our experience now, with almost 30 months of median follow-up of about 200 left main bifurcation OCT guided cases, we have stopped doing proximal distal crossing, and we are doing it exactly the way, the kissing and all those things. And we have not found any sort of major problem as far as the MACE and TLR is concerned. That publication, we are going to write on it, and you will see that publication down the line. This was the original traditional teaching, but we are now not thinking of proximal or distal crossing, and we are working, in a normal fashion. This was a 49-year-old male diabetic hypertensive presented with angiostomy, normal ventricular function, and angiogram revealed a tight 90% ostial left main lesion. Of course, we always use intravascular ultrasound for this. And here, we tackled it properly. This is the end result, which looks perfect. But when we did the post-stenting IVUS run, this is what we saw. Despite a very clean angiographic result, there was a damage to the struts of the stent which are protruding outside. And that has created quite an oblong type of lumen, which was corrected with post-dilatation. And this is how we got 11.44 minimum stent area, which is the perfect result. Another case of 65-year-old male, hypertensive diabetic, presented with a very high CT calcium score in the left main region with a normal ventricular function. And you can see a tight ostial left main. We went ahead to stent the left main ostium under IVUS guidance. But to our surprise, you can see there is a good amount of calcium. Of course, the lumen does not look absolutely circular, but minimal lumen area is 10.26. So we deferred the intervention. A 55-year-old male, diabetic, hypertensive, hyperlipidemia, NSTEMI, raised trop, class 3 angina, fair LV function, presented to us. And this was actually, in another country when I was giving a live demonstration in the national conference. And we had available in our armamentarium IVUS, OCT, and rotational atherectomy. We rotablated this lesion. What should be the strategy? Strategy was we rotablated this lesion. We did optical coherence tomography dilatation run after post dilatation after rota. We thought that everything looks good. Here we got stuck, and this is what after stenting we see. It looks very scary. Why it happened? Because the time slot was 35 minutes to finish my case, and I hurriedly interpreted the optical coherence tomography image in the proximal area. I thought everything has been rotablated, looks perfect. And then the rotablator, the optical coherence tomography catheter was simply refusing to go inside. And I had to use IVUS catheter, which has a better muscle, and I could cross it. And here you see there was a nodule which I missed, and that created problem. There was a hematoma, and the minimal stent area was very, very low in the very proximal LAD, 4.51. Fortunately, to my fortune, the nodule was towards the diagonal side of ostial LAD, and I could significantly dilate it to make it 5.5. And this retrospectively, when I interpreted the IVUS or OCT image, this is what happened. The message is, if you are doing it, imaging, spend good time to interpret it. Otherwise, you can create problem for yourself. Dilatation and then the satisfactory result. One more case is a 67-year-old male, hypertensive diabetic, class 3 angina, mild LV dysfunction, and this was post-bypass case. You can see, whenever I see this type of picture on angiogram, particularly in a post-bypass, long duration bypass case, without imaging, now I can at least predict that I have to encounter a very bad nodule in that region, calcific nodule. And then we try to initially break with the non-compliant balloon at a very high pressure, because here, sometimes giving a rotablator or whatever, at that time, of course, orbital atherectomy was not available. So we dilated. It is a very bad nodule there. You can see spiked nodule. 2 or 3 balloons ruptured, but we were able to break a lot of calcium at and around nodule, but we could not get the best of the result here. And we, from 3.17, we could create a 6.88 lumen, which was acceptable. Of course, it was not very nice to see, but here I have to hold in the interest of the patient, because if you try further, you can create 2 problems. Number 1, you can perforate the artery, and if not, then you do a stent fracture. If you do stent fracture, it is very, very significantly high chance of patient coming back with the restenosis or acute initial problem. And if you perforate, you are creating problem for the patient. So this is another case which was taken in IOPUS investigator initiated. These are the nodules with a spike, which are malignant nodules. And here normally the balloons don't work. You have to rupture the balloon, you have to damage the vessel in the surrounding, so you have to be careful. Even the lithotripsy does not work in this type of situation when the surrounding area is good and this type of nodule is there. With a limited experience of several cases we have done with orbital atherectomy, this is where orbital atherectomy helps because of its mechanism of moving around at the axis. It can, ablate and make it little more blunter for the balloon to open it up. And this is what, this is one case where you see the calcific nodule, spiked nodule there. It looks like a spiked nodule. And this is what you see on optical coherence tomography, a sharp nodule with a sharp edge there, and orbital atherectomy. And you can see a good amount of ablation there. And you can see the result was perfect after dilatation. And this is how it looks. Another similar case, you can see high CT calcium score. Here is a shelf lesion, which is a shelf-like lesion. At times you feel, if it occupies the whole area, you feel it is a membrane. But this, I was pretty sure that I am dealing with a sharp calcific nodule. Again, orbital atherectomy. This is what it looked, in OCT image, which we did before going for orbital atherectomy. Ablation done with orbital atherectomy, ballooned, and you can see how it was broken. And then with stenting, you can get a perfect result there. And this is how it looked, and this is how you achieve the end result. So what is the importance of calcium plate fracture? Again, a seminal, small but beautifully done study. Initially, the score was given by Fujino and Mahera, the calcium score, OCT calcium score, 1, 2, 3, 4, according to the amount of calcium less than 90, circumference less than 90, 90 to 180 and more than 180. 90 to 180 is 1, more than 180 is 2. And then the length of the calcium, more than 5 millimeter is 1, about 5 millimeter or more is 1, and the thickness, more than 500 microgram is 1. 1 and 2 means you can break the calcium with balloon, non-compliant balloon. 3 and 4, you have to use the technology. It could be rotational atherectomy, it could be orbital atherectomy, it could be intracoronary lithotripsy, or it could be cutting balloon, whatever. And then you have to break the plates. Why? What is the importance of calcium plate fracture? Again, a beautiful study by Akasaka et al. Most of the OCT initial seminal work has been done by Dr. Takashi Akasaka from Japan, a thinker and an innovator. A calcium plate thickness less than 500 micron was corresponding to cutoff value of predicting calcium plate fracture by high pressure ballooning without using any technology. So what does it mean? You can see how does it transform in clinical practice. Minimal stent area with a fractured calcium plate is higher as compared to non-fractured calcium plate, and stent expansion index is higher in calcium fractured plate as compared to non-calcium fractured plate. So how does it matter in clinical practice? It has a direct impact on the long-term result. Binary restenosis 14% vis-a-vis 41%, and target lesion revascularization 7% vis-a-vis 28%. Significant difference. So use imaging in any calcified lesion. And here, IVAS has scored over many situations over OCT, but many situations OCT is better, so they are complementary. We have a preference for OCT for most of the cases. But here, OCT will help you because you can create, you can calculate the calcium score, and accordingly you can decide your strategy, and you don't overuse the technology. and you use the technology whenever it is appropriate. So lesion modification should be attempted to reduce the calcium thickness if it is more than 500 micron, and try to reduce calcium thickness to less than 500, whatever technology you are comfortable with. More the calcium fracture, better it is always. And these are few examples. You can see 360 degree calcium, around 90 degree, more than 180 degree calcium. Here, high pressure ballooning leading to calcium fracture plate. Again, high pressure ballooning leading to calcium fracture plate. Rotational atherectomy will give you this sort of pulverized type of calcium disruption, and then you can break it with the balloon. Here, rota followed by high pressure balloon. You can see big sort of blocks of calcium once you have done the rota followed by high pressure balloon. Again, you can see many calcium blocks once you have done the rota followed by high pressure balloon. Baseline is like this. This is lithotripsy. Again, lithotripsy, sometimes you may or may not be able to appreciate the calcium fracture, but once you dilate with the balloon, and ultimately when you stent, you get an excellent minimal stent area. Only caution is, like if there is a calcific nodule and if the surrounding area is reasonably good or fibrous or non-calcified or normal, then lithotripsy, you are going to waste lot of pulses, and particular area it will not work so well, particularly in isolated, discrete, bad calcific nodule. Again, this is an example of the same baseline, shock wave, final. This is another example, shock wave, high pressure balloon, and final MSA. So the value of experience is not seeing much, but saying it wisely. Thank you very much for your kind. Thank you, sir.
Thank you, Dr. Patel. You have covered everything in a very lucid manner and very interesting cases you have shown. The message is well conveyed. As per your last slide, the value of experience is not in seeing much, but it is seeing wisely. That's the most important thing.
I have known Tejas for so many years. He spent some time at Just Look with me, and one of the brightest fellows that I can recall. And then thereafter he continued his good work after coming to Ahmedabad. And his entire efforts to popularize the radial catheterization and radial intervention with his book, a remarkable book that he has written, and he gifted it to me. And I find that his contribution in the field of interventional cardiology is unparalleled. And I think...
Thank you, sir, for your blessings.
And I think, as regards the question, I just only have one suggestion. For people, from practical point of view, let me say that what did I do and how did I deal with undilatable lesions in the days when the imaging was not available, because I have seen the spectrum for the last 55 years. Now, I take a balloon, visibly calcified lesion, open it with the non-compliant balloon, and if I said already that if you see that the dumbbelling takes place and the lesion does not break, I immediately switch over to rotablation. After using the rotablation, oversized balloon at a low pressure, like say in 3 millimeter artery, I'll use a 4 millimeter balloon at 1 atmosphere. You know the Laplace's law states that the tension at the wall of the balloon is directly proportional to the inside pressure and radius. Larger the radius, the inside pressure can generate the same amount of voltation. If that does not open, I switch over to a higher burr. And this way I call it as interpolated angioplasty. It would amount to sometimes my dilating the balloon on the rotawire itself. I don't want to change to something else. And although there is a slight slurness when the balloon has a rotawire is 0.009 and balloon is compatible with 0.014, but it does not matter. So this way you can, but I think it is true that if you can measure the thickness, which I think the only way the thickness can be measured is by OCT. You can't measure thickness with IVUS. So in that respect, I think in calcified lesion, the OCT scores. It scores over the IVUS. And I think it's a good thing that I think your treatment is very accurate, that if you find that the thickness is 0.5, I think you will not hesitate in debulking with ablation therapy, whatever you want to.
Yes.
Yeah, yeah. Orbital or rota,
Yes.
whichever it may. You people,
Sir,
yeah.
excellent talk, and I've been hearing from you that you want to do this talk. I could finally hear it from you. Images speak 1,000 words. So, sir, two important things. You are the person who has done maximum IVUS as well as OCT probably in the country. In the
Not
same
IVUS,
patient.
but OCT certainly.
No, the combination. So my question was, sir, in which cases, though it would be a rarity for somebody to have both the imaging modalities in the same patient, but you have done that probably in one of the largest series. We know from the Octavius trial that there is probably no difference in terms of the outcome. But, and also there is no difference in terms of the renal deterioration because of the myth that OCT will have more contrast.
Yes.
Even that is not true. MACE is not different. Contrast problems are not different. Then how would, apart from the left main and the proximal and the creatinine apart, would you firstly combine the two imaging and secondly choose between the two imaging?
When
Two
I
questions.
want to combine two images, I don't combine on regular day-to-day basis. This is just to create a good academic, sort of collection, because I am in the process of writing atlas on imaging, and probably it will be the first atlas of that kind in the world where OCT, IVUS imaging and discuss both in a very balanced manner. That is one. In my clinical practice also, intuitively I feel, now if I am working on a left main, which we are doing regularly now, and if I find that left main seems to have a diffuse disease throughout, right, which involves some ostium also, and then some mild disease and a critical left main bifurcation, I will open up both the catheters, IVUS as well as OCT, because I want to make 100% sure. Because the ostium of the left main, sometimes you don't see properly, or most of the times you miss with optical coherence tomography, and there, IVUS interpretation can help. And if you are not doing that, and if you are, despite you feel that you have done a proper pot, if you keep a space between, like 5.5 or 6 millimeter arteries, sometimes we get bigger arteries, space there between, the arterial lumen and the stand struts, then further intervention can be difficult. So we have to make 100% sure that you are doing a proper optimal pot at that point of time. Secondly, seeing the ostiums of the circumflex, I don't think any modality can give you a better image than OCT. IVUS will certainly not, because we have that experience. IVUS interpreters, like in Trico, you have seen, I don't know whether you have seen, Akasaka, Dr. Akasaka is a regular visitor. He and Dr. Saito, left main bifurcation and proximal and distal crossing, they were discussing on the basis of IVUS image. And then Malcolm Bell, who is the head of Mayo Cardiology, told that hardly anybody can understand what these two authorities are discussing and about this image. So that was a different level of discussion at that point of. Here with OCT, it is a naked eye scene, you can see whether it is a proximal crossing or distal crossing. Secondly, after so many bifurcation left main cases, we are going to write on it. It doesn't matter whether you are crossing proximally or distally. It is simply, the cosmetic image which looks better. If you have given good lumen at the carina, at both the places, nothing happens.
I tend to agree for two reasons. Gary Mills, when he was here in Bombay, and I heard him personally in so many meetings, there are two phenomena: immediate stent malposition, ISMA, and late acquired stent malposition, LASMA. Both ISMA and LASMA has not been definitely proved to be resulting into any kind of MACE. It is still to be seen. So therefore, he said that in the medium-sized artery, if you have a 5.5 lumen area, and if it is corresponding to an FFR of above 80, you are done. Any waste of time can lead to sometimes complications.
Yes.
Yeah. Vijay, we have three experts here. GS Chada, Vijay. So I want little input from both of you.
And as you said, overdoing is not good. So I think if you get a good lumen area and without a major under expansion, I think you should do. I think there are two small papers that have shown that if you over aggressively do it, create more injury and result in more adverse events. Then I think it is imaging again helps in where to stop also. It is not that based on imaging you do overdo things.
And I think, Ajay, you can say that. But I think, Vijay, the lasma is commonly seen when there is a positive remodeling or when there is an acute MI where the clot
Yep.
disappears.
And it is actually only one study from Korea that they followed up for 10 years, where they done a baseline imaging, 9-month follow-up imaging, where they see acquired malposition due to your polymer or stent related toxicity. That is the one going to be related to increased adverse events. And most of the time in ACS, you implant a stent and the thrombus resolves and create a malposition.
Yes.
And provided the stent is well expanded, and they don't result. And none of the studies have prospectively shown that malposition in a well-expanded stent result in adverse events. Even though there are small OCT studies, increased volume of malposition resulted in adverse events. But none of the major prospective randomized studies have shown that acute malposition create a major problem.
So one question.
You wanted to add something?
No. Just agreeing with what our teacher Dr. Patel said. This is about the left main bifurcations. So there was a small study called OPSI-BRAE that was published in Cath Cardiovascular, in which the only predictor of side branch failure was actually the presence of metal at the ostium of the side branch, and it didn't matter. I mean, unfortunately, we didn't see where we had crossed from, but the single predictor of side branch failure was the presence of metal at the carina. So I think that would be very, very logical in waiting for what sir has to publish.
Sir,
Good morning, sir.
Sir, I have one statement to make. I wish all the authorities
please
sitting
go
here
ahead.
will agree.
Yeah.
Most of the time, imaging is interpreted by the company person who is sitting there. I have taken it as a mission after radial that young generation of this country should know how to interpret the image by oneself. And by considering that, like interpreted image from the company person, you will simply commercially you will be upgraded, but patient does not benefit. And sometimes you can create blunders also. So I personally feel that everybody who is into imaging must learn how to interpret the image. And that is what, since last 3 tricos, we are struggling to make a point that you interpret your image yourself, and that will be better for you as your understanding of the pathology as well as for your patient's better outcome.
Very good.
Thank you, sir. Thank you.
Sir, so one question. Sir, we've been learning from you from my residency days and still learning from you. So when we were doing more and more imaging, so what we have realized with LAD especially is that when you have an ostial LAD lesion, the plaque extends to the distal left main. And even if you have disease till the ostial LAD. So whether it is better to try to nail the ostium, or you prefer to put a crossover single stent from the left main to LAD, recross into the circumflex. And second question is, even if you do that, what are the rates of restenosis of the ostial circumflex? Because when we try to nail the ostium, when we do an IVUS, we almost always find that there is some struts in the left main, even if you feel that you have nailed the ostium.
Good question. I think, let me tell you my experience. I have actually, when I work for my patient, I have 2 different souls working in myself. One is my clinical soul and one is my academic soul. And when there is a confrontation between my clinical soul and academic soul, I believe in my clinical soul. Because then I have under my belt more than 125,000 procedures experience, and I follow my clinical soul. Secondly, if you have this situation, again, if you have OCT, you realize whether that area has a fat embedded there at carina and the distal left main or not. If there is a fat and your proximal landing is inside the fat, just not to go inside, then restenosis is guaranteed. This is again the data from Akasaka et al. So you deploy your proximal and distal landing should be in the normal area. If it is not normal, then some calcium, some fibrosis is fine. But in a fatty region, when you deploy your landing zone, then restenosis is very high. So in that case, you cross over and then you do crisscross again. Another observation from our left main bifurcation series, what I have found is many times the circumflex is around 2.5 or 275 or even smaller than that. That's codominant to non-dominant. And when we take an OCT run from LAD to left main, we hardly see any strut in that region. One strut which is a little eccentric, this and that. We even don't do crisscross and leave the result as it is. And we are watching now, and observing the patients, and as of now, we have not encountered any misshape in that. I need to know from the other experts what is their feeling.
Thank you, sir.
Sir, one question, sir. Sir, here. What has your experience with contrast-free OCT, like with saline OCT? You have done so many.
See,
lectures.
again, you attend TRICO and we will show you how to give a good injection. Sanjay is the best injector, and when he does an injection, we see hardly any whirling. That is a technique. So you don't need that. And even if you use contrast 15, 20, 30 cc more, it cannot, harm your patient. But for the information, if you see the trade-off between what information you get vis-a-vis what contrast you inject, of course it has to be rationalized. The information is scores over, what against what contrast you are giving.
Thank you, everyone. Request Dr. A.B. Mehta, sir, to hand over a felicitation memento to Dr. Tejas Patel, sir. Yeah, last question, please.
Yeah.
So you, how do you determine your size of the stent, same as the imaging share, or you undersize? This is the problem where many times.
I am more biased towards my distal landing. Like if there is significant difference, like proximal landing is at 3.5 and distal landing is at 2.75, I will love to use a 3 millimeter stent and then do a proximal expansion. Just to make sure, because if the area is, if artery is bigger, then chances of dissection are less and you are more in a sort of control of the situation. Like in the artery which is 3.5 in the proximal part and 2.8 or 2.9 in the distal, you take 3.5 stent, there are significantly higher chances of doing distal dissection and landing up with giving one more stent.
Thank you, everyone.